Welcome to the Ottawa Lung Cancer Summit. My name is Michelle Wright, and I am the coordinator of patient support initiatives here at Lung Cancer Canada. I'd like to welcome everyone here today on behalf of our organization, both in person and online. I would like to acknowledge that we are on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. We recognize the Algonquins as the customary keepers and defenders of the Ottawa River watershed and honor their long history of welcoming many nations to this beautiful territory. I'd like to thank Dr. Paul Wheatley-Price and our volunteers for their help. This event wouldn't have been possible without you, and we are very grateful for all of the time and energy that you put into making this a success. I'd also like to thank all of our speakers for joining us and sharing their valued information. Lung cancer is too often a forgotten cancer, even though it's the most commonly diagnosed. We at Lung Cancer Canada work to support persons living with lung cancer, their care partners, and families with support services, education, and resources. Our mission is to educate, advocate, and support the lung cancer community. There are information packages located on the outside tables, and our speakers will be taking questions after each of their presentations. For those of you who are with us virtually, please feel free to use the chat to comment on the presentations and enter your questions in the questions for our speakers in the Q&A tab at the bottom of your Zoom screen. With all of that said, I'd like to welcome our first speaker, Dr. Paul Wheatley-Price. Dr. Paul Wheatley-Price is an associate professor in the Department of Medicine at the University of Ottawa and a medical oncologist at the Ottawa Hospital Cancer Centre, specializing in the treatment of thoracic malignancies. From 2016 to 2021, Paul served as president of Lung Cancer Canada, and he remains active in lung cancer advocacy.
You don't need to do that. Hello, everybody. Thanks for making the trip out here and for joining online. We were wondering about, do we book this at the Cancer Centre, and then people in the West End have got to get across town, or do we book it at Queensway, where there's some nice rooms, but then people in the East? And then we booked it here, and of course then there's no parking, so it's hard to get parking here. So anyway, we might move it around for next time. So anyway, thanks for coming. We used to do this annually before the pandemic. This is the first time we've been able to get back sort of in person. The idea of evenings like this is just to maybe give you some encouragement about what's going on in the world of lung cancer, and then some practical things as well. So we've got the evening sort of divided into two halves. So first, my colleague Dr. Chang over here and I are going to do is more sort of what's going on in the world of lung cancer, and then we'll have some food, and then in the second half we've got some couple of physiotherapists who are going to speak, Jenna and Renee, and then a social worker and a palliative care nurse, Katie and Olivia, and so they're more going to address kind of what are kind of things to think about when you get a serious diagnosis like lung cancer. So with that being said, I'm going to talk briefly about these three things. What can Lung Cancer Canada offer you? Michelle started to touch on that. What can you offer Lung Cancer Canada or the broader community? And then a little bit about lung cancer, kind of where we are this year. So this is the homepage of our newly released website. So it's been updated just in the last couple of months. So lungcancercanada.ca, and there's all sorts of materials and information and podcasts and all sorts of things that you can find through the website. So that's lungcancercanada.ca, and that's sort of in the materials at the front. So what do we do? Well, Lung Cancer Canada was founded over 20 years ago now by It was founded in Toronto by a radiation oncologist, a social worker, and the husband of a lung cancer patient. His wife had passed away from lung cancer. And it was not designed as a sort of a research or charity, but it was really around supporting patients and their family members with lung cancer. And over the years, we've grown. So it was, for a while, it was kind of, wasn't really Lung Cancer Canada. It was more like Lung Cancer Toronto. And now we've sort of expanded across the country. Our current president's from Nova Scotia. And we do all sorts of things. So some of you are part of the support group here in Ottawa, and Sophie Lebel is here, who leads the support group. There's also online support groups. There's peer-to-peer networks. If you want information or education, there's some. We produce a lung cancer guide. There's a whole pile of them at the front. You can feel free to take one. It's just been re-released. I host a podcast, so listen to my podcast if you want. That's how I'm going to become famous. We also do a lot of advocacy, sort of at government level, both provincially and federally, trying to push for approval of new treatments. We have been more recently in the sort of research world. Through donations, we're able to offer research grants. So there's all sorts of things that we're doing. And hopefully that will be really effective. We've got a thing over there called Kayla's Angel Fund on the right. I don't know if any of you may have known, a couple of you will have known Kayla Bradford. Kayla was a beautiful young woman who died of lung cancer in her 20s. Just awful. But she was amazing and kind of inspiring, and she and her husband Jordan did a lot of fundraising and established this fund called the Angel Fund, which is sort of very pragmatic funds, just to help pay for a taxi ride to get to the cancer center and things like that. So anyway, all sorts of things. But Kayla may have been at the last one of these we did, I think back before the pandemic. Okay, so if you want to get involved, please do. Some of you helping today, you could join a support group. That's, I guess, getting involved for your own benefit. There are these events. You could become a peer-to-peer person and support other people who have been diagnosed with lung cancer. We do have various advocacy events. So, for example, we occasionally are at Parliament Hill, or we'll go and meet with politicians, and it's fine for me to go and sit down with them, but they'd much rather hear from you. And when we go together, that's kind of more powerful. There's all sorts of ways you can get involved if you want to. If you find that lung cancer in your personal life is enough for you and you've had your fill, then that's pretty understandable too. Okay, so 2024, I don't know I'm a big Olympics fan, so I was glued to the TV in the summer, watching all the sports that you never watch throughout the rest of the 4 years, rowing and rhythmic gymnastics or whatever it might be. But here's some good news. So kind of on the podium is in 2024, lung cancer rates are falling and survival rates are on the increase. And this is crucial because we haven't really been it's been a bad disease, for too long. So I'm not going to try and show too many graphs, but the Canadian Cancer Society produces statistics about cancer every year in Canada. And this is a graph that shows the common cancers and how often they're diagnosed. And it goes back, as you can see on the bottom left-hand corner, you can see 1984. So this is looking over the past 4 decades. And I'll just take you through it. So the top solid blue line, that's the most common cancer diagnosed in men, which is prostate cancer. And the dotted orange line is the most common cancer diagnosed in women, which is breast cancer. And you can see what prostate cancer's come down a bit. Breast cancer rates have been pretty stubbornly persistent there. The blue line, the solid dark blue line, what kind of is projecting as black here, and then the dotted dark blue or black line, they're lung cancer in men and women. Men is the solid line, and lung cancer rates in men have been steadily falling over the past quarter century and more. Lung cancer rates in women haven't. They've just started to fall in the last maybe 5 years. But it was really worrying that actually lung cancer rates in women were continuing to increase just ever so slightly over the decades where they were falling in men. And now the rates of lung cancer in men and women in Canada are about equal. Unfortunately, if you add them together, the numbers of cases of lung cancer in men and in women, it jumps ahead of prostate cancer or jumps ahead of breast cancer and becomes the most common cancer still diagnosed in Canada in 2024. So the rates are coming down, which is good, but our population in Canada is growing. We're a growing country and we're an aging country. So while the rates are coming down, the actual numbers are not yet, but they will. Now, what about survival? So if people are diagnosed with lung cancer, what are the survival rates? So this is actually, flip it around, this is not the survival rates, this is the risk of, this is the sort of death rates actually. And you can see the black, now unfortunately lung cancer becomes the deadliest of cancers. But the rates are really coming down now. So the chance of surviving lung cancer is getting better and better year on year. And you can see over the last 40 years, the death rates from lung cancer in men have sort of plummeted, and among women have now steadily been falling for the last 10, 15 years. So lung cancer diagnoses, like the chance of getting lung cancer, that's falling. And for people diagnosed with lung cancer, the survival rates are increasing. So that's something to be happy about. I've given my professional life to lung cancer. I was just talking to Scott earlier about what was happening 15 years ago. And 15 years ago, it wasn't looking so positive. And so much has happened in the last 15 years. So you don't have to read all of this, but I don't know if anyone has used this ChatGPT, the sort of AI software. Has anyone heard of ChatGPT? No, I don't often use ChatGPT. But if you were to go into ChatGPT, you can ask it a question and it will give you this amazing answer. So I went to ChatGPT and I asked this question. I said, which cancer has made the most progress in the last 10 years and why? And amazingly, it spews out this whole page of answers, but it says, and I agree, in the last 10 years, lung cancer has made notable progress, particularly in terms of survival rates and treatment options. And then it goes on to list the reasons why lung cancer amongst all cancers is improving the most in the last decade. And I don't know everyone in the audience, but I know a few of you, and I know some of your stories and exactly where you fit into some of these improvements, that you're the direct benefits of some of these improvements. And I'm going to talk a little bit about those just briefly, and then we can have, if you've got any questions before I pass it over to Dr. Chang. Now, all of that is positive, but I'm an optimist generally in life. I have to be. I support a football team, soccer team in England called Bristol City. They're utterly terrible. So they haven't won anything ever, actually. They got to the final of a competition in 1956. But they're worse than the Leafs or the Sens. But they can do it. They've done it. But, there's a reality check here. So while I've hopefully shown you these nice graphs of lung cancer becoming, less common or and less deadly, still it's the most common cancer. So this is a table of what are the projected numbers of new cancers this year in Canada. So this is bang up to date. So I don't know if this cursor will work. As you can see up here, about 250,000 people in Canada this year are going to be diagnosed with cancer. In our lifetime, about 1 in 2 people will be diagnosed with cancer. The most commonly diagnosed cancer is lung cancer. So 32,000 people are estimated to be diagnosed with lung cancer this year, and that is more than anything else. So while there's a lot of reason to be very positive, there's a lot of work to do. And this is how we're going to do it. So these improvements are coming from 3 main areas. Lung cancer screening, I'll talk a bit about that. Probably the improvements we're seeing right now are not yet because of screening. Screening is too new, but screening could make the biggest difference. So I'll ask you when we're done about what you can do about screening, because you might say, well, why? I don't need screening, I've already got lung cancer. But who is eligible for screening right now, and how you can tell your neighbors, you can tell your friends or family members if they might be eligible. And then we'll talk briefly about immunotherapy. I see somebody who's benefited from immunotherapy, targeted therapies. I see people here who benefited from those too. So screening, the idea of a screening test, when we think about screening, most commonly we think of like mammograms to detect breast cancer, or pap smears to detect cervical cancer, or now you can do these things called the FIT tests, where the government sends you that letter that you need to send your poop off for a sample to see if there's blood in it, and that leads to a colonoscopy. So that's a screening test. Screening is the idea that you can detect a cancer at an early stage before it starts to cause any symptoms. If you have symptoms, well, you go to your family doctor or you go to the emergency department, and maybe it's already too late at that point. So is there a way to pick up these cancers before? And there is, and it's with a CT scan, and it's with a particular kind called a low-dose CT scan, so there's very little radiation, they're very safe. And Ottawa was one of the pilot sites in Canada as we tried to develop a national screening program. And now you can come here to the Ottawa Hospital, but across the region, Renfrew, Cornwall, Winchester, the Queensway Carleton, all offer screening. There are new scanners going in Arnprior and Almont. They're hopefully going to join. Pembroke's going to join in January. So screening is going to be available for people across our region. Now, to get into a lung cancer screening program, there's generally an assessment of, well, what's your risk? If your risk of getting lung cancer is so low, then you don't really qualify for screening at the moment. It's a common question I get asked, well, I wouldn't have been eligible for screening, so what about me? And we can talk about that in a minute. But the people who are at highest risk of getting lung cancer are those who have used tobacco for a fairly substantial amount of time. So if that's you, or it's someone in your family, or you know people who would be eligible for this, or you think they would be eligible, then encourage them to seek screening. And in our region, that's possible. The Ontario Lung Screening Program is not yet rolled out across the whole province, which is one of Lung Cancer Canada's big advocacy asks. There are now programs in British Columbia, Nova Scotia, Ontario, but parts of Ontario, but Quebec has a pilot. Alberta is just coming along online. There's still lots of places in the country that don't have screening. But if you know people, this would be a good message to take away, to say to them, hey, you know what, talk to your family doctor. If they don't have a family doctor, there are ways that we can connect them with the screening programs anyway. Okay, immunotherapy. I don't know if anyone here is a Lord of the Rings fan. Anyone watch Lord of the Rings? 2 hands. Star Trek. Star Trek, okay. And Harry Potter. Okay, so the thing that they all have in common is you can become invisible. So for Harry Potter, in those movies, Harry is given this invisibility cloak. He puts a cloak over him and he sneaks around, evading the teachers in his boarding school. Or that's Bilbo Baggins in Lord of the Rings. He has a ring, he finds the magic ring, puts the ring on and he becomes invisible. Or if you're a Trekkie, the Klingon ships could have this cloaking device and they would become invisible. So what on earth has this got to do with immunotherapy? Well, cancer cells essentially have a magic ring or an invisibility cloak that enables them to hide from your natural immune system. So if you and I were to get, it's wet and cold outside, if you and I were to get a chest infection, we get a bug, our immune system will naturally say, oh, that's foreign, that shouldn't be here. The immune system activates, it goes and kills the bacteria, and you get better. But because of this invisibility feature that cancer cells have, that doesn't happen. And so the cancer can just grow and grow and grow unknown to your body. So what immunotherapy does is it essentially takes the ring off. And then suddenly the cancer is now visible to the immune system. Now, the analogy doesn't work well if you're a real Lord of the Rings fan, because Bilbo, who's put the ring on to become invisible, he's a good guy. So when he takes the ring off, he then can be attacked by the orcs and the bad guys. So my analogy doesn't work that far, but the idea is that that the immune system can suddenly see the cancer. So this is a story that I like to tell about a lady that I looked after a few years ago. She's passed away now, but not from lung cancer. She was diagnosed with stage 4 lung cancer 8 years ago. And her family have always given me permission to tell her story. She's not originally from Canada, neither am I. She was from Serbia. And she moved to Canada 25 years ago to help her daughter, who had moved here and married a Canadian, to help her daughter raise her grandchildren. And she'd been here for 20 years, didn't really speak English well, and then gets diagnosed with lung cancer. And there's a scan up in the top right, and if I give you a crash course in radiology, that CT scan is sort of like a slice through this person's body. And the black is her lungs, the massive white thing in the middle is her heart. But I don't know if this will, can you see what I'm pointing at with the arrow there? So that blob there is cancer. And it's over there as well. There's a smaller one on the other side. And down here. And up there, those white blobs in the middle of the black lungs are cancer. And she was able to get immunotherapy. And we know that immunotherapy had a good chance of working for her because there's this chemical on her cancer cells called PD-L1. And that's a bit like the ring. Like she's got lots of rings on hiding the cancer from the immune system. And it gives us a clue that, okay, immunotherapy could work well here. And it did. And within a couple of months, those spots had gone away. She felt better. She went on immunotherapy for 2 years. She finished her treatment. She moved back to Serbia. And she lived the rest of her life in Serbia. And her daughter would send me photos of birthday parties that she was having. And she died a couple of years ago in her, I guess, mid to late 80s, but not from lung cancer, from sort of more other natural causes. So I love that story because it tells me that we're not doing treatments from my side of the table just for the sake of making a cancer disappear. We're doing it to try and restore people's lives. And we were able to do that really well for her. And I could tell you lots of stories about people who've done so well from immunotherapy, including someone who's in this room, who I'm trying not to stare at because that'll give it away. But so that's immunotherapy. And now targeted therapy, if you look on Lung Cancer Canada's website or in those booklets that are out there with the patient guide, there's this page will pop up about what different systemic treatments. So a systemic treatment is basically a drug treatment. It's a drug that will get through your whole system. And so there's chemotherapy, and then targeted therapy and immunotherapy. So targeted therapy is different to immunotherapy completely. So some people's cancers have very specific abnormalities in them, very unique to them. We call them driver mutations. So a mutation is a genetic mistake that causes the cancer to grow, and we call it a driver mutation because it's one mutation that drives the whole cancer to grow and spread and do the bad things that cancer does. And in people who have these specific driver mutations, we can target them with a drug. And we can be very specific in blocking that one mutation. And we've seen people just, again, have their lives restored and live for years healthily back to normal life because of these driver mutations. And if I'd shown this graph 15 years ago, when I moved to Ottawa, I would have said that there is one driver mutation that we know about, and it's the one on the left called EGFR. And now there are lots of drugs that can really effectively target that. And then there was a second one that came along a couple of years afterwards called ALK. That's the one in blue. And then there's just been an explosion of them. This scientific discovery has found more and more and more of these mutations that we can treat. So I know there are people in this room with EGFR, with ALK, with the one sort of near the top right, KRAS G12C, and there may be others here with other ones of those mutations. But these are all tablet treatments. You know, they can have side effects, but they're generally much easier. And they, again, have revolutionized people's lives. And you'll hear about that a bit later. This is an example of a young man, also actually from Europe, who'd moved to Canada. And he has this really, really rare type of lung cancer called ROS1. That's a 1 in 100 shot. We don't see that very often. When I first met him, his scan down here on the left, his lungs were full of this white stuff. He came in to see me in a wheelchair on an oxygen tank and was really, really sick. We started this pill called crizotinib. Within weeks, he was off oxygen, feeling normal, went back to Europe. He's on a different pill now. And that was, gosh, I don't know how long ago. So these things are just kind of, like from my side of it, they are so rewarding because when I started treating lung cancer, we didn't have any of this. And it was a bit of a dismal cancer to treat. And now it's just so encouraging. So I think I'll stop there just with this sort of final slide. As a charity, we're here to help you, and please take advantage of what we can offer. You know, the sobering thing is lung cancer remains the most common cancer in Canada, but there are so many improvements happening, and as ChatGPT tells us, faster than any other cancer. And because of these new things. So that's all I have, but I'm happy to take any questions. People have got questions here, or is Michelle here? Michelle might have stepped out. Winky, can you hear me? Can you moderate any questions online?
Yep, I can hear you, and I just asked the virtual participants for any questions in the chat box, and I'll relay them.
Okay.
So,
Does anyone have any questions here? Sophie? Yeah. Yeah, so for people online, the question was the proportion of men and women getting lung cancer. Yeah, so the rates really in Canada, well, in most places, because lung cancer is common and the tobacco is the biggest risk factor, the rates between men and women are largely aligned to cigarette smoking rates. And so 50 years ago, it was much more common in men, and now rates of cigarette smoking are roughly equal. I don't know if anyone saw, though, there was some stuff in the media just this weekend about the rise of cancer in young people. And there's certainly been that story about Kayla. Unfortunately, we still do see a slight increase in lung cancer, particularly in young women. But in fact, 2024 is the first year where there's meant to be more lung cancer cases in women than men in Canada. But it's about the same. Vaping? Oh, okay. So the question's about, does vaping cause lung cancer and where does it fit in? We don't really know if vaping itself causes lung cancer. It's a bit too soon. Vaping can certainly cause other respiratory conditions. I think what our big fear is that vaping gets people hooked on nicotine, and then they move on to starting to smoke cigarettes. So that might be the link. We're just about to actually at Lung Cancer Canada partner with a high school in Cowansville, which is a town in Quebec, and have students develop their own anti-vaping sort of videos and messages for them to tell their peers about. And we're going to support them with communications companies coming in, and they'll do trips to the local hospital to learn about it. And then we're going to encourage them to teach their own peers. Because it's no good if I go and speak at some high school assemblies and you can just imagine they just go, wah, 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 wah. They don't listen to me at all. Yeah. Okay, I'm glad you asked that. That question was about combining immunotherapy and targeted therapy. So the answer generally is no. So immunotherapy typically, not exclusively, but typically doesn't work so well in people who have these driver mutations. It's not entirely true across the board of them, but in general, if people have a driver mutation, which is probably about a quarter of people with lung cancer, then those tablet treatments are definitely more effective, and immunotherapy doesn't seem to work so well. In contrast, if you don't have a driver mutation, then yes, immunotherapy can work really well, but the targeted pills don't work. Putting them together doesn't seem to improve any effectiveness, but actually can be quite dangerous. So the early studies showed there were some quite nasty side effects when they were combined. So we don't really do that. But it was a great question. I should have mentioned that. Yeah. The BRAF mutation, it is a driver mutation. It's not very common. It's about 1% of lung cancers. Now, just to bring up BRAF or BRAF, that's one of our biggest sort of areas of anger, if you like, in lung cancer, and where we would like your support. BRAF mutations can occur in melanoma, a form of skin cancer, and in lung cancer. It's the same treatment. The government pays if you've got melanoma. They do not pay if you've got lung cancer. And when they made that decision, we were furious as a charity, as physicians, as patients. We wrote to them, we accused them of stigmatizing lung cancer patients. We did everything we could, and they just, in fact, it was approved. They couldn't negotiate a price, which was really sort of upsetting. Okay. Yeah.
Is the radioactivity cumulative over time? Like, does your body ever expel it, or it just stays in your body?
So for screening CT scans, the dose of radiation is so low that it's really very safe. Radiation exposure over time these days is pretty safe. In theory, there's a slightly increased risk of getting like leukemia 20, 25 years later. It's sort of theoretical and really rare, and you can argue that the risk of missing something by not doing a scan far outweighs what may happen in 25 years. And if you've got lung cancer now, and we're worried about leukemia in 25 years, that's a bit of a success in itself. So there's just behind you, Michelle. Maybe we'll do this one, and then if there's any ones online, and then I'll pass over to Dr. Chang.
There were a group of oncologists that wrote to the government about second and third line lorlatinib funding for ALK.
Oh.
And I'm wondering if there's been any movement from that paper and from that efforts.
Right. So, just to sort of explain that, ALK lung cancer is this one in blue here, and it's about maybe 3% of people with lung cancer have ALK, and there's been a lot of progress over the years as drugs have got better and better. So crizotinib was our first generation. That was sort of succeeded by one called alectinib, it's the second generation, and then the third generation is lorlatinib. We have had an issue that I can prescribe any one of those. They're all paid for and funded as one treatment, but nothing is paid for afterwards. So now, as it turns out, it looks like lorlatinib is so good as the first treatment that we're starting to move it to the first treatment, but it remains a problem that if people are on some of the other drugs and we want to switch, funding becomes a challenge. And so those are some of the things that we do at Lung Cancer Canada is trying to argue with payers to get these drugs. For that specific question, we haven't been successful yet. How much time do we have?
Probably.
Because we can also talk over food afterwards. But
We can, yeah.
Go. Yeah,
Okay.
yeah. And then we'll do one here as well. Yeah. Yes, it is. Yes, and a lot of drug companies will provide some co-pay support because these drugs are horrifically expensive. They could be $10,000 a month if you're paying out of pocket. Yes, if people have private insurance, that's great. But, we're in Canada. Not everyone does. We're in a government town, so a lot of people do. But. It depends. Yeah. So and different insurance companies will cover different things. There are, having any drug insurance doesn't mean that everything's covered. So there are ways that we try and beg and borrow and steal to get drugs, but it's not always easy. I've got one last one here, and then, yeah. Okay. Yeah.
How is Canada doing in approving new treatment drugs and then also for funding? in terms of comparing the world?
Yes, so that question is, how is Canada doing? I was at a meeting just at the weekend about this. Not great, not great. We're quite good at ultimately funding drugs. Most of the things that you see here, not everything, but most things are funded. Well, a mixture of those things are funded. And certainly better than a lot of countries. But the time taken to get to that decision is way longer than a lot of countries. So one of the issues that we were just actually discussing at the weekend with a potential change in government coming is how we can leverage that. But we're in a funny system, right? Because the federal government is not responsible for your healthcare, but they do have levers they can pull, the thing called the Canada Health Transfer, where the federal government sends billions of dollars to the provinces to support healthcare. So they can put conditions on that. But lung cancer has not been one of them so far. It's more around mental health or primary care. It gets very complicated to approve drugs. Health Canada tells us that we can prescribe a drug and gives it a license, but then there's further processes, a thing called a health technology assessment, which is bodies that say, okay, yes, it's available to prescribe, but should we be funding it as a society? If you get that approval, then it goes to another body to negotiate the price that the provinces are going to pay. And then if you get to that point, it goes back to each province to say whether they can actually afford it. If anyone ever watched a show called The Squid Game, did anyone watch The Squid Game? The Squid Game. Okay, so The Squid Game's a peculiar TV show. Did you watch it, Michelle? Yeah, it's Korean, I think, The Squid Show. And it's basically, it's kind of a bit gruesome, actually, the show. But basically, you start off with, I don't know, 250 people, and they enter this kids' games. But they're kids' games for adults where if you lose, you die. And you have to get all the way through, and then there's the last man standing wins a lot of money. And it's a kind of weird dystopian type TV show. But I kind of liken it to our Canadian healthcare system for drugs, because there's lots of games and hoops you've got to jump through, and the approval of a drug can die at any stage. And we've got, unfortunately, examples of all of them where, for one reason or another, funding's not got there. And that's one of the things we do to get that.
Yes, we do have one question online.
Okay.
Where is the science at with regards to using ctDNA and tissue biopsy samples for lung cancer diagnosis?
Okay, so ctDNA, so that stands for circulating tumor DNA, or our genetic material within our cells. And it's a very cool science if you're a bit science geeky like me. Cancer cells, some cancer cells naturally die. Doesn't matter about treatment or anything. Some of them, if you've got 1 million cancer cells, 100 of them are just going to die. And when they die, their genetic material gets released into the bloodstream. This is truly like science finding a needle in a haystack. So now the ability exists to take a blood test and to weed out from all of your normal red blood cells and white blood cells and everything, to weed out those tiny, tiny fragments of cancer DNA. And sometimes to be able to tell us what type of cancer it is just from that blood test. But it's also starting to be used now to monitor, if a cancer's coming back, might we be able to detect it with a blood test before it turns up on a scan? So the answer to the question is, right now it's just a research thing. It's not being used routinely, but it's something that might well be used routinely in the next few years. With that, I should pass on.
Yes.
Do you want me to introduce Dr. Chang, or do you want to?
Yes, please.
Okay. So this is Dr. Unice Chang. Dr. Chang is a medical oncologist here in Ottawa. She's doing some lung cancer research, and she's an educator. She's from Ottawa and then trained in the prairies in Saskatchewan, Manitoba. Oh, darn it. Manitoba, sorry to Manitoba and Saskatchewan. And came back to Ottawa maybe 3 or 4 years ago, 2 or 3 years ago, just over 2 years ago. And I'll pass it on.
Just a little bit forward.
Okay.
And if you can use, this should be
work.
working.
Okay.
And it's also got a pointer.
Okay. So, hi everyone. Thank you for inviting me to speak with you today. What I want to do is to very briefly go over some of the history of evolution of treatments in lung cancer. It'll be a little bit of overlap with what Dr. Wheatley-Price spoke about, but I think we could, shed light on it from some different angles. And then we'll also talk about some of the new treatments that are becoming the new standard of care within the last few years, as well as future directions that are currently going on in research that may well become standard of care in the coming years. I want to convey all of my nerdy excitement about how cool some of these new treatments are, and I want to avoid any overly technical jargon. So I've provided some hand-drawn cartoons for you guys to enjoy throughout the presentation. Okay, so back in the 80s, 90s, and even the early 2000s, really the only tool that we had to treat lung cancer that couldn't be cured with radiation or surgery was chemotherapy. And basically the way that it works is it does DNA damage in a fairly untargeted way. And the goal is to damage rapidly dividing cells more than other cells in the body, but it kind of hits everything. So here's the first cartoon. So you got a little normal cell, it gets a little bit of DNA damage, and it does what a good cell should do. It stops dividing, and then it repairs its DNA and moves on with its life, still a happy little cell. But then you have cancer cells, and they really, really like to divide. And they've lost some of the, mechanisms to repair their DNA or to, stop and fix things when they get DNA damage. So they go on to divide even more and more. And what that generally does is it multiplies the errors in their DNA. And with chemotherapy, we're hoping it damages the DNA to the point that they can no longer just do the basic functions to keep themselves alive, and then they die. So this is what we call a survival curve from back, published in 2002, where they were looking at 2 different chemotherapy regimens and comparing them. And how survival curves start is at the beginning of a clinical trial, 100% of the patients are alive, and then they follow them over time and see how the patients do. Okay. And back when chemotherapy was our only treatment, the 1-year survival in the best and fittest of patients who qualified for these clinical trials was somewhere in the realm of 40%. The 2-year survival was much lower than that. And back then, when you did a clinical trial in lung cancer, you didn't even need to follow them to 3 years. You could just stop after 2, and you would have all the data that you needed. So, very, very depressing. But that was back then. So, immunotherapy, as Dr. Wheatley-Price has spoke about, was a very, big game changer. And the way that it works is to activate the body's immune cells to attack and kill cancer cells. So here's another cartoon. You can think of our immune system as a security guard that's, trying to decide what should and should not be in the body. And the cancer cell has these little disguises or signals that say, don't kill me. And the goal with immunotherapy is to block all of those disguises, all those don't kill me signals, and get the immune system to do what it's supposed to do, and expel or get rid of the cancer cell. So this survival curve is from one of the big immunotherapy trials, and was published in 2006, I believe. You can tell it's newer than the original curve because the journal article is now published in color. As the blue line on top was the survival of the patients who are on immunotherapy, and the red line was the patients who were the control arm and just got the traditional chemotherapy. As you can see, the 1-year survival was much, much higher. Same with 2-year survival. And even more encouragingly, you can see that as you go out to 3, 4, 5 years, the survival curve looks like it's flattening, meaning no more patients are progressing in their cancer and dying, and some of them are experiencing long-term disease stability, which is even more encouraging when you realize that with this trial, patients stopped immunotherapy after 2 years. So they're not on any treatment, and they're having cancer control. In medical oncology, we generally tell patients, like, we don't cure you. Like, the surgeon might be able to cure you, the radiation oncologist might be able to cure you, but our treatments can only, kind of improve cure rates, maybe keep your cancer under control for a while. But now we're starting to get these patients where they ask us if they're cured, and we say, no, but you're not on any treatment and your cancer is under control. So that's, something that we love to be able to tell people. A lot of the decisions that medical oncologists make in terms of recommending what they think is the best treatment for patients is based on these clinical trials where they spend a lot of money, a lot of time, a lot of effort to generate these survival curves. And we like to say when there's a really huge difference between the new treatment and the old treatment, saying you could drive a truck between those curves. So I put a little truck here just to demonstrate how big of a game changer this treatment was. Now, with targeted therapy, during the same period of time, people are researching the biochemistry behind cancer. They're finding these mutated signaling pathways that are telling these cells to just divide and multiply over and over and grow. And they found that they're able to design molecules that kind of block up these signaling pathways and turn that growth signal off. So another cartoon. So you can think of, a mutated cancer as an open doorway where somebody's just yelling through it, divide, 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 in a very annoying and repetitive way. And a targeted therapy is standing in that doorway, blocking it up and telling it to shut up. So here is a survival curve from one of our, poster child targeted therapies, so osimertinib or Tagrisso for EGFR mutated lung cancer. The great thing about targeted therapy is that it generally has an extremely, extremely high initial response rate. So you can see like the 1-year survival on osimertinib is over 90%, which is way better than chemotherapy, but also better than immunotherapy as well. The problem with targeted therapy is that it doesn't tend to have that flattened survival curve near the end where people are having long-term disease control. We do expect everyone on targeted therapy to eventually progress and need some other kind of treatment, which is where there's a lot of active research going on. This trial was comparing osimertinib to a previous generation of targeted therapy. So the difference wasn't quite as drastic as when it was compared to immunotherapy, but I was able to sneak a truck right in the middle there. Okay, so that's where we are now, you know. Lung cancer is a lot less depressing than it used to be, but there's still a lot of advancements that need to be made. What are some of the treatments that are becoming the new standard of care? One is preoperative or neoadjuvant chemoimmunotherapy. So the traditional approach when a patient has a curable lung cancer that can be surgically removed is that you undergo surgery and then you recover from that, you go see the medical oncologist, and after a discussion, you do adjuvant chemotherapy. And then some people these days may also qualify for immunotherapy after they complete their chemotherapy. So with preoperative treatment, you're moving both the chemo and the immunotherapy to before surgery, then you're having the surgery, and then some of the trials that are looking at this then add a year of immunotherapy after the surgery, but it's unclear whether or not that is necessary. So what are the advantages to doing preoperative treatment? So one, you know, chemotherapy, immunotherapy can be quite tough on the body, and it might be easier to tolerate when you still have all of your lungs and haven't had a major surgery. So we expect more people to be able to kind of complete their full treatment of systemic therapy than if they have it after surgery. Two, the treatment might shrink the tumor and make the surgery easier. Hopefully, you know, make the surgeon's job a little easier, make sure they have, you know, clear margins when they do the surgery. And possibly if it shrinks enough, you know, they might have to take out less lung. Third advantage is that we can actually see the effect of the treatment on the tumor. So you get the treatment, and then after they resect it from surgery, we can take that sample and look at it under a microscope in the lab and see how much of the tumor was killed. And we do have some patients on these trials who get what's called a pathological complete response. And what that means is when they look at the tumor under the microscope, all of the cancer cells are dead. There's nothing there except scar tissue and inflammatory cells. And from these trials, we know that's a very, very good sign where it's very unlikely that the cancer is going to come back. So that's really valuable information for us and for patients to feel confident that, you know, the treatment that they went through, you know, did something. Because one of the very common questions I get in patients who are on treatment after surgery is, how do I know if this treatment is working or not? And the answer is, we don't know. We only know we're going on faith that it might help you on the order of 5 to 10% maybe. And we have no way to know in a particular patient if, you know, the systemic therapy that they're suffering through is actually helping them at all. As we spoke before, you know, immunotherapy tends to not work in people who have these targetable driver mutations. So they require a whole other set of clinical trials and a whole other set of treatments to advance their care. And targeted therapies have typically been reserved for if you have stage 4 or metastatic lung cancer. And now it's moving forward into the curative setting to be added after surgery and after chemotherapy. So, you know, as we spoke before, we don't necessarily expect these targeted therapies to like permanently get long-term disease control, and we don't really know if they increase long-term cure rates, but we do know that they improve survival. And one of the mechanisms that might be explaining this is that if you have very few cells that are hiding out in the body that are cancerous, and you're suppressing them early on rather than waiting to see if a new tumor grows in the body. If there's a fewer number of cells, it may be harder for them to start developing resistance to the drug, because it tends to be as they're dividing and getting new mutations that they develop drug resistance. So the fewer that are there and are dividing, the less likely it is that any one of them will develop resistance. And then, as we spoke before, we need to do separate research for all of these targeted lung cancers, because immunotherapy doesn't work well, especially in the targeted types of lung cancer that are associated with, not smoking. So what's coming down the pipeline that might revolutionize our treatment in the coming couple years? Something called antibody drug conjugates. So our body's immune system produces these little Y-shaped proteins called antibodies, and normally they're used to attack foreign substances. And people are able to go into a lab and design antibodies that target specific proteins and markers on cells, and specifically ones that we know are found on cancer cells. And what antibody drug conjugates do is they take that targeting molecule and they attach it to a chemotherapy molecule. And the goal of this is to, throw more chemotherapy at the cancer cell and less chemotherapy at the rest of the body. So hopefully more deadly to the cancer cell and less systemic side effects. So you can think of traditional chemotherapy as, kind of carpet bombing the whole body. So, you got that one cancer cell that gets hit, but the other normal cells also get hit, and then they have to rely on their ability to recover. And then with these antibody drug conjugates, we're hoping it's more like a homing missile that will go straight for the cancer cell and leave your normal cells alone. Bispecific antibodies. So normal antibodies in the body have this little Y shape, and normally both the arms target the same marker, the same protein. We're now able to manufacture ones where each arm binds to a different target. And what you can do with these is actually, quite a bit of different stuff. So one, you could just block two targets. So if you're doing targeted therapy, perhaps you have two pathways you want to block, you can just use one drug that blocks both of them. If you're doing immunotherapy, there's, multiple immunotherapy targets. You could theoretically design one that just blocks more targets at once and potentially is more effective. We also know that you can design one arm to find cancer cells and the other arm to, bind to immune cells in the body and hopefully draw it in and get it to, attack the cancer cell by just bringing them into close proximity. So we're, currently enrolling patients in trials that use bispecific antibodies, and hopefully that will, start to get reported in the coming years, and hopefully a lot of them will show good benefit for our patients. And then more immunotherapy targets. So the vast majority of patients who are treated with immunotherapy are treated with something that blocks what's called the PD-1, PD-L1 pathway. But there are tons of other, what we call checkpoints, where the immune cell is looking at cells to see whether or not they belong in the body. And there's lots of research going on to see if we block other ones, whether or not we're able to help the immune system, recognize more cancer cells and get those response rates higher. We want, more patients to be able to get to that long-term cancer survival. So that's everything I had today. I hope you can, appreciate the vast progress that we've made in lung cancer and look forward to what's coming in the future.
So we are a little bit over time. We're about 17 minutes, but does anyone have questions for?
I think I can project.
Okay, good.
I just wanted to know if you had any idea of time frame for these new treatments, the antibody drug conjugates.
So we currently, like, there's currently trials ongoing, and there's been, some trials that were unfortunately negative in terms of benefit. So I'm not aware of like one that's, already has a big trial that proves the benefit and is just waiting for funding approval. So probably not, kind of next year, hopefully in the next 5 years. I don't have, timeline there.
Yeah, and that question was on the biconjugate drugs.
Not specifically, but definitely, using vaccines to prime the immune system and make them recognize cancer cells is something that's also ongoing.
I could jump in. There was just a couple of weeks ago a drug, one of the bispecifics. There was a positive study in China. So it's not yet ready for prime time, but those studies are now happening in Canada with that drug. The China results look really promising. That was one of the going for the 2 for the price of 1 drugs. There are these vaccines in the past have been really unsuccessful, but there's a new group of vaccines that they're called microRNA vaccines. So RNA is part of the genetic material that we have, and there's a new group of vaccines that are being developed. The way it would work would be, and we're going to open a study shortly, is people who've had surgery for their lung cancer were then able to take their lung cancer and we send it off, and it's like a personalized vaccine gets built based on that cancer. And then the vaccine comes back a couple months later and you get a few shots.
Kind of.
Well, the COVID vaccine is sort of generic. Everyone gets the same one. This is personalized to your own cancer. So that's, it's very experimental at the moment, but, we're a little interested in it. That's the one that was in China. That's the one, yeah. That's not a vaccine? No. It's not a vaccine. That's one of Dr. Chang's two for one.
Yeah, it's a bispecific. Yeah.
One of those. So it targets the immunotherapy, and it also targets a pathway that starts the cancer of new blood vessels. Yeah, so that's the one that we do have studies of that drug in Ottawa. It's called ivonescimab. There'll be a quiz.
Any further questions? No? I'm just going to check online. Thank you, Dr. Chang. And I know we are running a little bit behind, and we do have dinner waiting for us, but Dr. Elena Chu wanted to briefly talk about a study. They told me just before the break, so.
Hi, everyone. Not a doctor yet, but hopefully soon. I'm a PhD student working with Dr. Sophie Lebel, so some of you maybe know her. She's in the back there. And I just really wanted to quickly update on some research that we're doing. Our lab, it's called the Psychosocial Oncology Lab, and we focus on, or my research, program of research, focuses on the experiences of people who have lung cancer and are receiving immunotherapy or targeted therapy. So we've been really lucky to work with Lung Cancer Canada in the past to do some research, and maybe some of you have participated in that. And we did an interview study to look at what are the concerns and worries and needs of individuals receiving this treatment. And so right now, well, what we found was that people have a lot of psychological concerns and worries that happen right at diagnosis, a lot of fear that comes up around diagnosis, and then a lot of uncertainty that happens while they're receiving treatment. And so this is a follow-on study from that original interview study. This one is running out of the Ottawa hospital, so the Ottawa folks here may be eligible for this study. And really, we're looking at some of the psychological concerns that people may experience. We're using questionnaires, which means it's online, but you can receive a paper copy version of it. And we do all the screening in the background. So if you do qualify for this study, you'll receive a letter. The letter looks like that. So if you see that in your mailbox, that's the one. There's a QR code that you can scan to participate in the study. And yeah, we really hope to be able to understand what particular concerns people have so that we can help design interventions or supports that are tailored to individuals in this population or with immunotherapy or receiving immunotherapy or targeted therapy. And so it's really, if for those who have filled it out, thank you. And for those who haven't filled it out, if you do see this, we would really appreciate if you had the time to fill it out. Yeah, so the email there is livingwithlungcancer@theottawahospital.ca. So if you are not sure whether or not you've received this letter or you received it and it got tossed and you'd like to receive another one, you can either call that number or email. And I know we're running late, so do we have time for questions if anyone has any?
Does anyone have any questions?
Okay, well, you can find me near the food, and I'll be happy to answer any questions. Thank you.
I hope that you had a chance to speak with your fellow participants and some of the experts that we have here today. I'd like to introduce Jenna Gregan. Jenna is a graduate of the University of Toronto's physiotherapy program. She's been a practicing physiotherapy for almost 25 years. She started out in sports medicine and has worked in both Canada and the UK. And she's been with the Ottawa General Hospital's Cancer Centre Psychosocial Oncology Program in outpatient care for the last 16 years.
Hello.
Thank you.
So my job today is hopefully to try to give you some ideas on how to maybe make breathing or yourself more efficient when you're choosing to do exercise. You should all have in your hand in those little packages just some key notes. So I just wanted to try to make this as practical as possible so that you can have things that you can kind of get started with today even. So if you want to follow along, I did not do a PowerPoint presentation, sorry about that. But the keynotes are in your packages. Yes, everybody's got them, perfect, good. So the first thing we're going to just speak briefly about is diaphragmatic breathing. You probably hear that a lot, but there's a very good reason as to why diaphragmatic breathing would be the best way to breathe if we can. It's it's an endurance muscle. It's meant to last all day long. And if we are breathing here, that's a very expensive way to breathe because these muscles are power muscles. They're meant to go on and then go off, whereas the diaphragm is a nice, slow guy that can just last all day long. So how do we know that we're using our diaphragm to breathe? Just as a little exercise, you can put your hands on your belly. When we take our breath in, the hands will rise. When we breathe out, the hands will fall. Okay, so when we can, choosing to use the diaphragm to breathe, those nice deep muscles, instead of, and we're going to go into more reasons as to why that's not a good pattern, that would be the better way to go. So number one is the diaphragmatic breathing. The next thing we're going to go to is called altering our breathing rhythm. This is probably my biggest push. The thing that costs us a lot in breathing is getting the air in. That's using muscles to get the air in. When we exhale, it's just a relaxation. So sometimes we get caught up in the, and that's really inefficient. What I prefer, or what I would like you to try to do, is just focus a little bit more on the air coming out. So to change that ratio a little bit. So we take a little breath in, but we spend a little longer on the breath out. You can see it's not costing as much energy to keep trying to shove that air in. Okay, so focusing on the exhale. The exhale is that key piece. The next part to that breathing strategy is using something called pursed lip breathing. What does that look like? It looks like, so what's happening when we do that, when we purse our lips, the air hits the back of the lips, splints the airway open, creates a back pressure, splints the airway open a little bit longer to allow for a little bit more oxygen exchange. It also helps us to just kind of slow our rate down a little bit. So what is that going to look like? Our little breath in, a little longer on the exhale. So when something's going to cost you a lot of energy, say climbing this set of stairs potentially, then we can use that strategy before we even start the stairs. Instead of just at the top, we do it before we start to stop that from happening if we can, or at least to mitigate that effect. So it's a breath in, okay? So we've got our diaphragmatic breathing, we've got our focus on the exhale, and then we've got our pursed lip breathing. So they all couple nicely together. And then the fourth thing on that page is something that all physios love to talk about, and that's posture. But there's a reason why we talk about it in this scenario. You can try it now. If we're in this position, slouched in your chair, when I take a breath, you can tell how much effort it's taking for me to take that breath. I have to make it happen. Whereas if I'm sitting up tall, now my ribs, which need to flare to allow for space for that lung to expand, they flare on their own. There's no barriers. I don't have to make that happen. So if we're in a good seated position, shoulders back and down, chest up, there's no barriers to these ribs moving. I'm not making that happen. It makes us more efficient. In fact, a max efficient could even be arms overhead, because then you're actually getting a bit of that thoracic extension as well. Less effort, more effort. And we want to conserve energy wherever we can, okay? So those are my 4 biggies. In terms of sometimes we do, well, not have the greatest posture, or we're using these big muscles to breathe, so things get tight. I'm in a hunched forward, so chest, poking chin, so I'm tight through my neck and shoulders. So how do we undo some of that? Well, we're gonna start by changing our practice, but we may already have that tightness, so we've got to address that. So I've chosen 4 muscles. They're in your handout there. These are the best ones to focus on. So what is the process? What is that going to look like? We start at the top. Well, they all start with your shoulder being low, side bend away. So we're opening up that side. That's your upper trapezius. I don't count it. We give it a good long hold. This is the best place to focus on the exhale, because when we're breathing out or letting the air out, we're relaxing, we're going to get way more of a stretch. So I give it 2 good long exhales. So then we've done the side. We're going to hold that position, so we're staying in that side bend, that shoulder is still low, but now we're going to look down towards the ground, and you're going to feel that stretch more at the back of the neck, at the top of the shoulder. 2 good long exhales. Once we've done those, we've got a collarbone here. Our palm is on the collarbone. We're pulling it down. We're going to close our mouth, and we're going to look up towards the ceiling. And you're going to feel that stretch across the front of the neck. So those are your neck stretches. We'll do it once on the other side. Shoulder low, away. hold. Shoulder low, look down towards the ground. Hold our collarbone, look up towards the ceiling. 2 good long exhales. And then the other big muscle that can get tight is that chest muscle with those shoulders coming forward. The picture is there. It's a pec muscle. Elbow resting on the side of a door or the side of a wall. About 90 degrees is a good place to start. You may have to go a little bit up or a little bit down depending on where you're more tight. And we turn away. And where you're going to feel that stretch is across the front of the chest. Same idea, you don't have to count it. Go into your relaxation mode and focus on the exhale. Because you get that good relaxation with that. Just a couple of other considerations that you can think about. Potentially if you're out for a walk, maybe using something like Nordic poles is a good workout. That gets you using your core, that gets you integrating the arms. You can practice your breathing when you're doing that. Our streets get a little bit slippery, so it gives you 2 more points of contact, so it does help with balance and stability as well. Another thing to consider is potentially a stationary bike, one of those nice recumbent ones that have a full chair. You can use it all year round. It doesn't matter if we've got snow and ice outside. They're really inexpensive. You don't need something fancy.
Attention, attention, code white, D Delta 6, code black, D 6.
Just one other consideration, if you are doing any sort of light weights, which of course I encourage, the more efficient your body is, the better, but you might think about timing your breath with the weights as well. So it would be a breath in and a breath out. So you're breathing out with the effort, the same as what we said about the stairs, okay? The other thing is just don't be afraid of a little bit of shortness of breath. A little bit of shortness of breath when you're training, not at rest, but when you're in training mode is a good thing. If I was to give you a scale of kind of 0 to 10, 0 is no shortness of breath at all, 10 is the worst you've ever felt, ugh. I would say if you're in training mode, you're out for your walk, or you're doing stairs, or you're doing your weights, if you're kind of in that 3-4 range, you know you're creating change, okay? Using all of these strategies, but you do want to have a little bit. You don't want to always be comfortable, because that's a maintenance. If you want to see change, we've just got to, I'm not going to say redline it, but you've got to push it just that little bit for a little bit of time, and then use your strategies to bring the breath rate down, and you can use your stretches afterwards. And that's all I have for today.
Thank you so much. Is there any questions?
Hello, can we get some of that leaflets? Those of us who are not there, can we have some of that exercise?
She didn't get the handouts for online.
Yes, I will be able to send the handouts to you after this session, unfortunately.
Thank you.
Is breathing the way you're suggesting, does that actually expand the lungs, or do your lungs always stay the same size?
I would say I would use it as an exercise. So the one that I keep harping on about the exhale one, you can actually get a much deeper breath if we do an exercise where you actually exhale until you've got nothing left. Then that next breath, you're going to feel that reflexive spring. It's going to feel right down into the base of the lungs. So you will get that air right down into the bottoms.
Your lungs actually expand.
Well, they're constantly expanding and contracting, yes, but if you're thinking of something is deflated and you're looking to inflate, like an athlete, yes, you can, with your breathing, trying to get the air right down into the bases of those areolas, yeah.
Any other questions?
Gentleman in the red shirt.
Sorry.
This is about sedentaryism. I heard there's a thing called dead butt syndrome.
Let's hope we don't get that, yeah.
Okay. Is there an easy way to address it?
You're talking about trying not to be sedentary? What?
Yeah, well, when you don't have a lot of energy.
Yes, okay. So an accommodation could be, well, the stationary bike would be one, because you're sitting and you're just moving the legs. You're not going to go for an hour, but you might go for 30 seconds to a minute, take a break, repeat. Other alternatives would be chair exercises. There's a ton of stuff online. A really good program that I like is called Senior Shape Fitness, and it's got a real mix of things. There's none of the jumping and the heavy weights, but it is more about posture. It's about balance and stability, but she's got a whole segment of exercises sitting in your chair in terms of maybe doing a bit of weights, or maybe you're just moving the arms, maybe you're doing some stretching, you're working on your breathing, but there's tons you can do just from sitting.
Thank you.
Yeah.
And there's also the Excel program too.
There is?
They will work with you to develop an exercise program regardless of your fitness level, and it's developed specifically for cancer patients.
It's a 12-week program that runs twice a week. And they do start with lower things. It's being conducted by health professionals, so they're assessing you while you're there. They start at lower exercise levels and progressively try to add as the weeks go on, but of course they accommodate depending on the person and their capacity. But really a chair program would be where I would start. If you're sitting, you're stable, you're not worried about your balance or your stability, you do what you can. You might need to modify some things, but at least you're doing something. When you stop doing stuff, and we lose that energy, it's very hard to climb out of it. But if we can start something and just stay even, I'm not looking to increase, but even just stay here, then you're gonna have a much easier time with it in terms of treatment. Okay. Anything that makes you get a little bit short of breath or a little bit of resistance, like maybe you're using water bottles or 1 pound weight, something that's just a little outside of your auto resistance, that would be of value. And consistency too, trying to do a little bit of something every day.
Hi. I guess, you're saying don't push too hard and blah, blah. So people that have had surgery, like I blow balloons.
Okay.
Like, would that be pushing? Because it's hard, right?
You're using it as exercise?
Yeah.
Go for a walk.
Oh, I do that.
You do that too.
But I have grandkids, so I blow balloons for them all the time.
Gotcha. I can't blow a lot of balloons. I get a little lightheaded. You're considering that in terms of the lung capacity? I'm sure it is. Anything you're pushing up against resistance, why not? Make it fun for yourself. But the idea is just something, a little bit, but often. Yeah.
Okay.
I like that idea of the balloons. That's good.
Yeah, it is actually, because like when I started, I could do 1, and now I can do 7.
So you measure your success and you feel good about it. Nothing bad about that. That's great.
That is great. I also have never heard of that.
Yeah, I'll use it. Yeah. Balloon ball, are you kidding? We do that all the time.
And how many days is it months to do exercise? How often?
How often?
Yeah.
Every day.
Every
Is that
day?
an overreach? The reason why I say every day, and it doesn't look the same all the time, I mean, that could be going out to get your groceries that day. That could be going for 1 lap around the block. That could be a chair exercise program that you do. It looks different every day, but I aim for every day because if you miss a day or two, you're still going to see benefit. If you aim for exercise twice a week or 3 times a week and you miss a day or two, you won't get that benefit.
To a fitness program.
Sorry, I was
And if you are on a treadmill, okay, treadmill.
Train?
Sorry, we couldn't quite make out what you were saying. If you could type it in the chat, maybe?
Where do I see that? Oh, you've got the chat. Okay. Well, you can always forward a question to Michelle.
Yeah, you can always
and the
forward a
questions
question
can always
to-
come back to me, and I'm happy to answer
Yeah,
those.
to info@lungcancer.ca and lungcancercanada.ca, and I'll make sure that we get that answer for you. Thank you, Jenna. So next we have, actually. So next I'd like to introduce Olivia Desjardins and Katie Nichol. Olivia Desjardins graduated with a bachelor's degree of social work from the University of Ottawa. She went to work at CHEO and for the Children's Aid Society of Ottawa, and returned to U of O to complete a master's degree in social work. In recent years, she completed a certificate of business through the University of Guelph. Oh, okay, Katie, are you coming down? Or, oh, I see you're tag teaming. Okay, thanks. Go ahead, Olivia.
Hi, everyone. Just do next, perfect. So, I'm Olivia, I'm one of the social workers at the Cancer Center, and I'm the intake coordinator of a program called Psychosocial Oncology. We're a support program through the Cancer Center. Basically, our program, to give you an overview, and for those who aren't familiar, we're on site at the Cancer Center at the General. Some of us are at the General and some of us are at the Irving Greenberg, which is the Cancer Center attached to the Queensway. And we're a team, and our goal is to support people and their loved ones through cancer. So myself and Jenna, we work as part of the Psychosocial Oncology program. So before I get into the different patient support resources, I just want to acknowledge that lung cancer, or cancer in general, can be a roller coaster, can feel like a roller coaster. There's a lot of emotional impacts related to having a diagnosis, and regardless of where you are on your cancer trajectory, it's a lot. And it all stems from change. Being diagnosed with cancer is a big change in your life. There can be changes in relationships, changes in your day-to-day. So I want to acknowledge that what you're going through is not easy. And really, you guys are the experts here, but what the emotional impacts of cancer are, and the practical impacts, but there's tons. There's repercussions on your livelihood, let's say ability to work, tolerance to activity, that sort of thing. But my goal here is to explain that you're not alone through all that. And that essentially some people feel the need to reach out for support. Some people don't necessarily feel that need. They have good friends and family, and that kind of fits the bill. And other people need more help, and that's okay. So I was mentioning about our program called Psychosocial Oncology, and essentially we're a team. So social workers like myself, we have a psychologist, we have psychiatrists, physios like Jenna, dietitians, and speech language pathologists. And we all kind of work together to meet you where you are. We offer a few different classes and groups within our program. So right now, for example, we have a class called Money and Medication. So that reviews different income supports, drug coverage matters, anything that you could think of really in terms of the government programs. There's a coping with cancer stress class. So one of our social workers runs this, and it's different coping strategies, how to kind of calm your mind, how to calm your body, how to recognize when we have those kind of red flags within ourselves, kind of building that toolbox to help us, cope with cancer in a different way. We have a Kids Matter class. So it's intended for patients to participate, not for the kids, unfortunately. but it's to educate parents or grandparents on how to support the kids through the cancer diagnosis. So how to talk to them in age-appropriate ways, what to say, how to be there for them through their emotional reaction with it. We have a psychotherapy group called Accent. So one is ran by our psychologist and one is ran by a social worker. That one is more of a support group style as opposed to the 3 top ones that are classes and just one-time things. And we'll be starting shortly. It's called the Fear of Recurrence Therapy. It's an implementation study. So some similar themes, but again, a psychotherapy support group. For loved ones and caregivers, we have a class called Someone You Care About Has Cancer. So kind of like a caregiving 101, how to support myself through the cancer, how to support the patient who's ill, what can I do, what's within my capacity, what are some self-care strategies. And our dietitians run a class called Food is Medicine. But these are kind of the groups and classes that we have in-house. So to access us, you could either ask your cancer care provider for a referral, or you can self-refer. You can self-refer either by leaving us a voicemail or coming to see us in person. And I have our locations there. So at the General, we're on the 1st floor of the Cancer Center, right by Radiation North. And at the Irving Greenberg, that's again the Cancer Center attached to the Queensway, we're on the 1st floor and it's just across the radiation reception desk. So we recognize as well that, psychosocial oncology, we're an acute care program. Sometimes you don't necessarily need to speak to a psychologist or a social worker, but you're just looking for a resource. You're looking for maybe a support group or to connect with other people who have cancer, and that's where our community partners come in. So these are kind of examples of different tiers of support that exist. So the first is just our information or resource centers that again are at both cancer centers have a resource center that have all these booklets resources. They're usually staffed by a volunteer who's able to kind of help you pick out the guide that you're looking for. And we know that everybody has informational needs, right? So sometimes that fits the bill. With Cancer Care Ontario, there's also booklets online through their website. There's symptom management guides. So, how to manage lack of appetite or shortness of breath, feelings of anxiety or fatigue. So Cancer Care Ontario through the Ministry of Health has all these guides that you could look at. And of course, the Canadian Cancer Society website's really reputable. And they have online called a Cancer Connection. It's like a chat that's really well enjoyed by people through their website. The mental health crisis line, I give this out like candy. I think everybody should have it in their back pocket. Don't have to necessarily be in crisis to call. It's just nice to know that somebody is there at the other end of the line, even in the middle of the night. The Cancer Foundation, this is probably our biggest partnership. So the Ottawa Cancer Foundation is on the corner of Alta Vista and Industrial. It used to be called the Regional Cancer Foundation, or some people refer to it as the MapleSoft. But it's this really beautiful building and it's a cancer hub. So they host different programs that they've started in-house, but they also host, for example, Lung Cancer Canada is having their next support group at their hub. They have other events, and everything is completely free. They have Simmer and Social, where everybody enjoys a meal together and just kind of chats. They have exercise, yoga, Reiki, they have foot care, Again, it's all totally free. It's just a really good resource. They have cancer system navigators, so if you're looking for something really specific, you can pick somebody's brain. And they also have psychotherapy supports, which again are one-on-one, they're completely free. So their website online is always kept up to date. You just click on the calendar, you register for the class, and it's really easily accessible. Of course, Lung Cancer Canada, there's peer supports. You're able to connect with a social worker. Her name again? Kate?
Miss Kate Cook.
Oh, Kate Cook. So she's a social worker specific to Lung Cancer Canada who you can request a chat with. There's the online national support group for patients, and there's also another one for caregivers. So there's a lot through the website as well. The Wellspring is another one, kind of like the Ottawa Cancer Foundation, where there's just so much available through them. It's all online. They're based out of the Toronto area, but essentially they have art therapy, Tai Chi, yoga, support groups, music therapy, anything you could think of. Their list of programming is very extensive, and it's just a matter of registering. For things that are more kind of practical in nature, so let's say you're looking for somebody to help with housekeeping or transportation or respite care at home, the Champlain Community Support Network through the website called CareDove is really good, where you put in your postal code, and then from there, you're able to click on the type of service you're looking for, and then it shows you which agencies service your area. And then you have the phone numbers, and you're able to kind of follow up with them that way. And then, of course, there's Ontario Health at Home, which is in-home home care. You have to be eligible for it, and usually it's more, or not usually, it's professional services. So if you need a nurse to come see you, if you need a personal support worker, if you needed an occupational therapist to look at equipment, but that you would talk to your care provider for referral. And again, there's us and psychosocial oncology, or PSOP is the acronym. Any questions? I know I kind of gave you every single resource within a short period of time, but I think the take home is that everybody's going to need something different, and there is a lot out there. You're not alone.
So at some point you said, you can ask your caregiver to refer you. Shouldn't they just be telling you about these things to begin with? Like, I've had cancer for 6 years, and I've had no idea. Like, I figured if I went looking and find things, but I had no idea that so much was available right here.
I think,
you would think in 6 years,
yeah.
somebody would have told me.
And we have to do a better job at leaving our pamphlets out in waiting areas and things like that.
But even the doctors,
Yeah.
nurses that come in beforehand, but, here's some information. Take it or leave it, but there it is.
I hear you. I think sometimes it's a matter of time, right? They have you in clinic and they're thinking of, okay, what do we need to do to get to our next step? And I know that when at the first consultation, you usually get like that purple bag with all the resources in it, but sometimes it's one more bit of paperwork that you don't have the energy to review. But I hear you.
And when you've heard that diagnosis, you're not paying attention to the purple bags.
Yeah, exactly. Well, this is good feedback for us to have. Yeah. There's not one at the table, but I'm happy to send it to Michelle.
Yeah, and I can send it out to everybody who signed up. Mhm.
Yeah, happy to send that out. And in the back, our pamphlets are there for the PSOP program. And there's other paperwork up there, but I'll let Katie speak to that.
Thank you. Next we have Katie Nichol. Katie's a nurse with the supportive and palliative care program at the Ottawa Hospital with over 20 years of combined oncology and palliative care expertise. She's currently pursuing further education to become a nurse practitioner.
Short and sweet.
Thank you.
Hi, everybody. So, as Michelle said, I've been a palliative care nurse for many years, and all of my experiences within our palliative care and oncology practice. And this is actually something I feel very strongly about advanced care planning, that it's important for everybody, not just people with an illness or when they get an illness. It's something that we really should all be doing at different points in our lives. Sometimes an illness is like the impetus to kind of really think about it and get going on it, though. So we'll chat a little bit just about some of the resources and kind of what advanced care planning is and why it's important. I love this motto about hope for the best and plan for the rest. A lot of times it's hope for the best, plan for the worst, but we can have an ideal scenario and that just doesn't always play out the way we hope. So kind of planning ahead for what that might look like usually just serves us well down the road, whether our treatments and program goes well or if things change at some point. So we'll talk about what advanced care planning is and what some of those resources are to support. So advanced care planning kind of as a larger concept is really, it's a process of reflection and communication. So it is thinking about the things that you want for yourself, for your care, that is hopefully communicated verbally to those that are important to you, but also written in some capacity to help guide those if someone has to make a decision on your behalf. The other part of advanced care planning is really thinking about who would you want your person to be? Who is that point person? If you need someone to speak on your behalf at some point and you can't do that, who do you want to be that person to speak for you? And if you see the little photo or the picture on the bottom, it really is kind of thinking about things that are important to you, learning about your illness, learning about what's going on, making decisions, talking to the people that are important about those decisions, and then recording it so it's kind of documented in a way that can be used if needed in the future. And again, I really feel strongly that this is something that's important that we do kind of at different points through our lives. A very quick scenario, my dad, when I was in undergraduate nursing, my dad was diagnosed with ALS. And his journey was very short, but 10 years before that, Susan Rodriguez, who some of you may remember, was a woman with ALS out in BC. And she actually wanted the right to be able to have assisted death. And 10 years before my dad's diagnosis, I can remember as like a teenager having a conversation in our family about things that he would want, things that he wouldn't want. He was a carpenter. We lived up in the bush. Those things were important to him. So fast forward 10 years, he has his diagnosis, and we didn't even realize, but we were having goals of care conversations before we even knew we needed them. But all that to say, as his illness changed, we already knew what was important to him, and that helped guide some of his decision-making, but also helped us in our coping and our understanding of his illness and what was important to him moving forward. I think that's why I landed in palliative care as well, but so there's multiple pieces to this, but at the end of the day, they all kind of come together to help guide your care. And at the end of the day, we want you to be able to express what it is you want, right? You're in charge of your life. We want to be able to keep that. If things change, then someone has to step in, but we want your care to be based on what you want, what's most important to you. And so that takes time and reflection and communication to get to that point. And I think the piece that also comes, so, you know, thinking about your values and wishes and thinking about who that person is important. And then at some point, if we get an illness, which at some point in our lives, most of us, 90% of us are going to have something, a chronic illness. That's a lot of people. So at some point, those little blips in our health are points that we can consider and reflect and make changes about the things that we want or maybe that we don't want, which then lead to having goals of care conversations and really thinking about what it is that we want when we're talking about consenting for care and treatment. So, difficult discussions. There's an elephant in the room, right? And it is human nature for us not to want to have these conversations, right? Lots of us are turtles. These things are hard to talk about. Sometimes we're not ready. Sometimes our loved ones aren't ready. We're worried about upsetting our loved ones. And there's a lot of uncertainty, particularly at the beginning of an illness, right? There's a lot of information coming. There's a lot of unknowns. But they are still really important. And I really still feel strongly that it's important to have these conversations when we're actually not in a time of crisis. Because at some point, things, you know, may go really well, but at some point, things may change, and making decisions in times of crisis is actually really hard. So we do know from science and research that there's lots of benefits to actually having goals of care conversations. We know that it actually improves people's quality of life often. We know that there's a lot of decreased anxiety and depression because sometimes talking about those things takes a weight off of your shoulders of things that you've been thinking about or that your loved one has been thinking about, and you just haven't been able to talk to each other about it. We know that it helps you have care that's consistent with the things that are really most important to you. We know that there's easier decision-making for families, and I go back to the thought about my dad and how it was a lot easier for us to be able to kind of be along for that journey with him. And we know that there's better satisfaction with the care that people get because it's actually congruent with the things that they really do want at the end of the day. I love this quote. Conversation about things we can't control actually gives us a sense of control. Right? It's very true, right? We can't control this journey. At the end of the day, we can maybe have a little bit of say, but we may not have control, right? It may continue on its path, and we can't change that, but we can make decision points along the way that feel like it's giving us that we are making decisions about. These are just a few things to think about and to ponder, and we're not going to go into them now, but I think they're important things to be thinking about that help make decisions. Thinking about what's most important to you during this journey. They don't have to be, do you want to be DNR or not? I'm talking more broadly about what is most important to you. How do you want to be spending your time, right? As things change, that comes into play. Oops. Do you have a substitute decision maker or a power of attorney yet? Have you completed your will? Again, doing these things early means that they're off your shoulder, you don't have to worry about them, and if and when things do change, they're done. They're one less thing for you to be stressing about. Some really important components of advanced care planning, and this is really to kind of empower individuals, is understand your illness, ask questions. You're here, which obviously tells me that you're curious and want to know more anyways, but ask questions. That will help give you information to make better decisions. Reflect on your values, your fears. Those things all come into play when you're making decisions. Identify a substitute decision maker by assigning a POA and talk to them. And it's an ongoing process. As at different points in your illness, you may revisit these things. The things that I would want now might be different in 10 years or 15 years or 20 years if I get an illness that's going to change that course. A couple of things for self-reflection, and these kind of questions help us make decisions with you guys, right? If I ever come and meet any of you, I'll be asking you things about these questions. What makes your life meaningful? What do you value, right? Those things help us to help you with the decision-making. A bit more kind of nitty-gritty, the difference between a POA and an SDM. So a substitute decision maker is someone who can make healthcare decisions on your behalf if you are not able to make that decision for yourself. As long as you are able to make a decision, POA and SDM actually are totally irrelevant. At the end of the day, if you can make a decision for yourself, that's the most important person that we need to look to. If you cannot make that, that is when we have to look to an SDM. And on the right, you can see kind of this, if there's no power of attorney document, we look to this hierarchy to figure out who would be your substitute decision maker by law. So most of the time, we'll be looking at the green space, which would include a spouse or a partner. Then it either goes to parents or to children, and then downwards. But usually, we don't have to get that far. But a power of attorney, so those of you who have done that legal document, probably with a lawyer, that trumps anything. But you do not need to do a POA with a lawyer, just FYI. That document can be done with a single witness. And actually, we have some resources at the back on the way out. We have some packages with some advanced care planning resources for you guys. Just a couple of resources with regards to thinking broadly. There is this really great program. It's a website called the Waiting Room Revolution, and it has multiple different aspects to it. So one of them, they have a book, Hope for the Best, Plan for the Rest, and it's really about navigating illness. It's tips for people, not just with cancer, but more broadly, understanding illness, how to navigate it, how to advocate for yourself. It's really great. So Dr. Sammy Winemaker is a palliative care physician, and Dr. Sien Sao is also a researcher within palliative care world, but they really look at illness more broadly. They also have a podcast, which basically takes this book and breaks it down. So if you're more of an audio-based person, that can be really helpful, and it's accessible. And another excellent resource is called Advanced Care Planning Ontario. And it's a really long website, but advancedcareplanningontario.ca. They have lots of resources to help navigate decision-making, how to pick a POA, there's an online workbook that you can do. We also have some packages with those same resources in them, so you can take them home and look at them at your leisure. Because, it's some light reading, but it's really important reading. Yeah. Does anyone have questions? It's a lot to cover, and it's not everyone's favorite topic, but I actually really feel that should be a public health approach. Like, we really more largely need to be doing this. So, yeah. Are there any questions? Yeah.
I have a question, but I think about it a lot.
Okay.
And I'm quite healthy and full.
Which I'm happy for.
But doesn't mean I will be in 6 months. But the question is at what point do you talk, and who do you talk to about me?
Okay. So, yeah, that's different for everybody. And I think some people like to have it in their back pocket. They like to know it's an option. From a palliative care perspective, I would be one to say, like, we would support people to talk about that if it's something that they want to explore. But I would also want to make sure you have good access to palliative care, because I think people worry that they're going to have symptoms or they're going to have things as their illness change that make them scared. And that's very reasonable. But I think, like, and I personally, we refer patients to have MAID all the time. They explore it with a team, and that team is really amazing at kind of answering questions and delving into some of that content a little bit more. It's going to be, my answer is it's different for everybody depending on what's going on. But there's no right or wrong, but at the end of the day, you can self-refer to MAID if it's something you want to talk about. There's a regional program housed here.
I'm just one of those, you know.
Yeah, you're thinking ahead and, yeah, yeah.
And yeah, so I can just refer to them, talk to someone about it.
Yeah, yeah, you can, there's, the regional program is housed at the Ottawa Hospital. You can find it on like the Ottawa Hospital website. Yeah, yeah. Oh, Dr. Wheatley-Price.
I'll say it out loud. So, if anyone, if you go on the Lung Cancer Canada website, there's the podcast, and the initial donors that supported our podcast here. Thank you, Marielle. So that's been going for about 5 years now, and you mentioned
Cien Xiao.
Winmaker. They've been on the podcast talking about this kind of thing. Sophie's been on the podcast. Marielle's been on the podcast. There's a podcast about MAID in there. So there's some neat stories and information, just to shamelessly plug the Lung Cancer Canada podcast.
Good to know.
Yeah, and they're all available anywhere you get your podcasts. So Apple, like iTunes, Stitcher, anywhere else.
Are there any other questions around like advanced care planning? Okay, well, thank you.
Thank you so much. So we are clearly quite a bit over time. We were about 17 minutes over time, but I hope that everybody can stay a little later because the next presentation is a patient panel, and one of the more important things I think that we do. So let me introduce our patient panel. You can, yeah, so you can sit there. You guys can come down. So our patient panel members are Kathleen Joy, Scott Paulsen, and Wendy Charbonneau. And our moderator here is Sophie Lebel. Scott Paulsen was from Minnesota and moved to Ottawa in 2003. He worked in social services until being diagnosed with stage 4 lung cancer in 2010. He's worked with youth at the Y, and his hobbies include gardening and travel. Wendy was born in Ottawa and has been married to her husband, Robert, for 57 years. They have 4 adult children, 9 grandchildren, and 4 great-grandchildren. She has volunteered at the Brain Injury Association of the Ottawa Valley for over 30 years as program director, and served on both the Ontario Brain Injury Association Board of Directors and the Brain Injury Association of the Ottawa Valley. She's currently a caregiver, mentor, and an advocate for brain injury. She enjoys traveling and plays percussion in the Ottawa New Horizons Band. Kathleen is from Ottawa and is married with 2 adult children. She's a registered nurse who was diagnosed at the age of 55 with stage 4 lung cancer in 2023. As she only had a cough and is a non-smoker, it was quite a shocking diagnosis. Dr. Lebel is a clinical psychologist with a focus on cancer survivorship and psychosocial interventions. She has contributed to the definition and measurement of fear of cancer recurrence and was the recipient in 2015 of the Canadian Association of Psychosocial Oncology Early Career Award. Thank you all.
I'm going to move that here, and I'm going to ask you for that microphone. Okay, so we'll decide who starts, but...
Don't speak in the microphone. The audience online will not be able.
Okay, so as we are about to get started, I'm just going to do a very shameless plug as well for our support group. It's here in your pamphlets, so once a month I have the privilege of helping with Lung Cancer Canada host this support group that's held at the Ottawa Cancer Foundation and also online at the same time. So let's welcome our 3 panelists. Thank you very much for doing this. I really appreciate it. And I guess we'll start with Scott.
Yeah, I'm going to look at my notes to keep me on task. On Valentine's Day 2010, I woke up with a shadow in my left eye, and I found out within a few months that I had lung cancer, non-small cell, and also brain cancer. So I found out there was no stage 5. And it was a poor prognosis, and I was told that to get my affairs in order. I had treatment for chemo and radiation, and a nurse asked me what I did for a living, and she said, well, this is your job now. And I had been taken by the hand and told what to do and was given structure. But when it was all over, the treatments, I asked, well, what now? And I had side effects from treatment and drug side effects. And I was enlisted at Breyer in palliative care. Their program was not care, but program. And for rehabilitation and cognitive behavioral therapy. Next, I went to the Maplesoft Center and was provided programs such as laughter yoga. That sounds like a small thing, but it became something that was very important in the middle of the night when I would wake up with throat spasms. It would relax me, and it does something to your brain. So it would help me get back to sleep. And so just, it was one way of dealing with anxiety of going to sleep. So that was just one little thing I picked up from the many programs that are available at Maplesoft. So this is where I also became involved in Lung Cancer Canada's support group. And I've been going for several years, and it's been really wonderful. I encourage people to go to it. And yeah, that's one of the reasons I'm speaking here today, because I believe that it is worthwhile. So between traditional chemo and targeted trials, I spent a number of years using alternative therapies. And this was before I got on trial drugs that were targeted therapies. And that was at the Center for Health Innovation. And most of the things I did there were acupuncture, vitamin C infusions, and mistletoe injections. And I can't say that there was one thing that really helped me, but I think it probably got me to the point where when the targeted therapies started as trials, I made it that far, because I was amazed at I was still alive. And that was like 6 years in. Oh, and also I found out that the doctors and nurses and staff who helped me at the hospital, at the cancer center, were good, but then in addition, GPs and nurse practitioners, and especially pharmacists, who were very good at using Google in a way that I would not trust myself to trust, what I found on Google. they were very helpful because they knew also how things interacted, what drugs interacted. And I've had a lot of brain fog because I've had radiation to my brain, and I think in general, we know what that's like with cancer patients. And I still write down things on lists, and I carry it with me from room to room because as soon as I leave a room, I forget what I'm doing. So it's something that I still do. It's been very helpful, and I've decided not to say I've forgotten, but to say I remember. It gives me a different perspective on it. So I guess something I learned recently was when you're looking at the rest of your life and you're to that point where like you no longer are working, and you say, well, what were you doing at the age of 10? What was it that made you happy? And that gives you an indication as to what might make you happy in the future. And I was swimming, I was collecting stamps, and I don't collect stamps anymore, who does? But I found that my interest was in history, in art, and travel, and those are all things that I do now. And I no longer can swim, I don't have the lung capacity for it, but every day I go to the pool and I do aquafit. And I can no longer cross-country ski, but I can do that in the pool. I no longer row, but I can do that on the machine. And if you're lucky enough to have a hot tub, it's a good way to relax your muscles. And I have some side effects from chemo still in my legs, which mean I can't stand very long. And so it makes that all possible. And even the yoga I would find difficult to do, I can do with a hot tub. It makes it easier. And I guess in a pool it could be done too. So that's pretty much it. I think that I recognize that few lung cancer patients that I've known have had the opportunity to live this long. I found that out when I was at the OICC or doing the vitamin C. We were all, this was 14 years ago, we're all looking for ways to find alternative treatments. And that's why we were there in the first place. And so I got to see what worked for people and what didn't. And so I've seen a lot of people go away. And but this is, I think with all the innovation that we've been hearing about, it gives me hope, more than I would have had 14 years ago. And that's it.
We'll have a period of question for all of our three speakers at the end, but I do have a question for Scott. My question would be, I guess it's been so many years now, that in terms of coping long-term, we've talked a little bit about that. So how do you find that, what helps you cope now that you're quite a few years out?
Well, let's see, getting in touch with people who I kind of lost track of. I moved, and also I'm at that age of retirement, and so are a lot of my friends, and we're finding each other again. We kind of picked up where we left off. Apart from that, staying active is very important, whether it's walking down the hall, walking outdoors, even the smallest thing, every day, like the physiotherapist said. Because sometimes you'll find yourself going further, just even if you don't feel like it. And there's nothing wrong with making it shorter if you need to.
Okay, thank you. All right, I'm not sure, do you want to go next, Kathleen? Okay, yeah, ready? Sure.
Can everybody hear me?
I think so. Yeah,
Yeah.
great.
I too have a few notes that I'm gonna check now and then, but when Sophie asked me to speak, I put a few things together, and one of the things that still is really prevalent for me is, how can I have lung cancer? And that's what I said when I was diagnosed at 55, January 5th, 2023. I had never smoked in my life. So when we received the diagnosis of stage 4 cancer, you can only imagine our shock. And so my family's cancer journey began then. Our future was not clear, and we were all scared. I have 2 adult children. I wasn't able to carry on with my career that I had worked my entire life to build. My husband and kids didn't know how long I'd be with them. My full-time job became attending doctor's appointments and trying to learn how to stay alive. The leading cause of cancer death in Canada has an identity issue. Lung cancer is responsible for nearly 1/4 of all cancer-related deaths in the country. More people die from it than breast cancer, colorectal cancer, and prostate cancer combined. Due to underdeveloped screening guidelines, almost half of patients are diagnosed at stage 4, which is an incurable stage. So how can lung cancer, the most commonly diagnosed cancer in Canada with the highest mortality rate, receive only about 6% of research funding? There is an outdated notion that lung cancer is a smoker's disease, even though thousands of never smokers are diagnosed each year. Around 28% of those diagnosed are not related to tobacco. This myth creates a stigma that stifles funding for everything from research to support programs. And so I guess for me, it was very timely that, hope for the best, plan for the rest that you put on the slide. I'm reading that book right now. And it was referred to me by my counselor that I see. And so 2 recommendations must be good. I'm taking things one day at a time. It's still shocking some days. Other days are better. I can't control that, but I've recently tried to process what I can control, and like advocating and reaching out and talking at a summit are things that I can do that I can control, and so I need to try to focus on that a bit more. Thank you.
Yeah, I think you said that for you, the message about if you have lungs, you can have lung cancer, right? Can you tell us a little bit about the stigma that you feel is around lung cancer, what you've experienced maybe?
Well, I think I've bumped into people that when I've told them I've had lung cancer, they're like, I didn't know you were a smoker. Things like that, just making assumptions. And I think, some of these stats and some of this reality from our culture, from our society, that, if you have lung cancer, you must be a smoker. But we need to change that. But, it took a long time for us in our society to realize how bad tobacco was for you, so it's going to take time for this as well, I think.
Okay, thank you very much.
Well, I was diagnosed with stage 2 lung cancer, was one of the very lucky ones, I guess, thanks to my conscientious family doctor and the doctors and staff at the Ottawa Hospital. I was diagnosed in September of 2018. I had originally gone to the doctor complaining of pain in my right side, just below my ribs. And he said he thought it might have been just a pulled muscle because I had just come back. Our band had gone to Ireland, and we were carting our instruments around, and he thought maybe I had done something to pull a muscle. Anyway, but also decided that he would have order an X-ray. So we had the X-ray, and then the radiologist saw a mark on the right lung. So the family doctor investigated further, and I was sent for a CAT scan. From that point on, in September, from September to November, I had CAT scans, PET scans, MRIs, blood work, and all to take me to the Regional Cancer Center, where I met with Dr. Sebastian Gilbert, who is a thoracic surgeon there, some of you might know, and he explained the outcome of the X-rays and the scans to me. He also said that the biopsy should be done. If it came back positive, then I had two alternatives. I could have surgery, or I could have radiation to shrink the tumor. He explained that if I chose the radiation and it didn't work, then surgery would probably not be an option. The surgery at the right, so I decided to have surgery, but on this journey, I chose not to tell my children until I had a definite diagnosis. And I had my sister coming with me to all my appointments. So she was the extra eyes and ears. So I had surgery on the 16th of November, and I had a right upper lobectomy, which is simple surgery through the rib cage and right at the level of my right breast. And usually it's an overnight stay at the hospital, but because I am a caregiver for my husband, they decided that I needed a rest and I should stay in until my birthday on November 19th. So from that day, I then met Dr. Stewart, who was my oncologist, who offered me adjuvant therapy, which I started on the 21st of January. It was one treatment for every 3 weeks. It was carboplatin with Pemetrexed. And because I developed tinnitus and some hearing loss, they lowered the dosage of carboplatin by 20%, third treatment. May 2019, Dr. Stewart ordered the CAT scan, and everything seemed to have cleared up. There were no, they were watching some small nodules, but there was no growth in these nodules. So he suggested that if the cancer reoccurred, that because I was EGFR mutation, it would make the cancer sensitive to pill form of treatment. Dr. Stewart and I agreed that it didn't make too much sense for two doctors to be following me, so Dr. Gilbert, the surgeon, would follow me for the next 5 years, and that I would be discharged from Dr. Stewart's caseload. So for 5 years, I was lucky. I had one scan a year. The small nodules were still there, but nothing was happening, and that was great. But in December, when I thought I was going to get my clear bill of health, I had my final scan, and I thought, they noticed two nodules in my left lung. They're still small, but Dr. Gilbert, again, offered to do surgery. But because I had planned a trip with my sister to Scotland and Ireland, I said, no, we'll watch them. So that's where I did my trip, and now my husband is on the list for surgery, so we're still watching. So hopefully nothing comes of these things, but and I think if I've learned anything with this journey is that positivity and your attitude, it helps a lot in your recovery. Having had the experience with my husband, it's been easier, I guess, for me because I've already walked that path once. And I try to do everything on my own. Don't do that. Encourage your family to get involved, your friends. They want to help. They don't want to sit back. They want to hear how they can help us. So use them, and certainly use the supports that are out in the community. And thank you to the Ottawa Circle support group. It's been a major benefit to me. Thank you.
Thank you. I'm aware of time, so why don't we ask some questions? If not, I'll have a question for Wendy, but anybody has a question or comment for our panel here? You have a question, so.
Yeah. Wendy was talking about stage 2, she was diagnosed. How often does that happen? Does anyone know? Dr. Wheatley?
Dr. Paul? All right, sure. Somebody, stage 2. Stage 2 10%.
About 10 to 15% would be stage 1, another 10% stage 2, about 25% stage 3, and 50% stage 4. But importantly, the people who go through screening and are diagnosed through screening, the numbers completely flip around. So instead of 75% of people in stage 3 or 4, you're diagnosed because you had symptoms and problems, you're diagnosed out. Suddenly it's 75% stage 1 or 2 if you're diagnosed through screening. So that's why we really want to get a message out that people are eligible for screening to get CTC.
Thank you.
I wonder if Wendy could comment a little bit about negotiating that with her healthcare team, right? This trip, for example. So how do you go back and forth with, sort of saying, well, these are my values. We talked about that values are important, goals are important. And for you, that trip was really meaningful, and then made that decision.
I guess, yeah, I'm fortunate enough to have a doctor in the country who has a little bit of extra time to sit with you and talk. We used to live in the country and then moved back to Ottawa. But I think they maybe have more time to be more personable. It's important, I think, to share with them all your concerns. Like, don't negate anything, in your own mind. Share everything with them, and they were. I can't say enough about the doctors. They were excellent in my care, anyway.
Thank you. A question or comment? Maybe sort of a last question, which would be, I think all of you are probably going through that roller coaster. Wendy mentioned, focusing on positive. Kathleen, you're mentioning advocacy. Scott, there's reconnecting with people, there's being active. Anything else you would add as kind of, for people that are maybe starting on this journey, in terms of, some of the things that have helped you the most to date? I know, it's a tough one.
For me, getting like emotional support, because I felt like it's a roller coaster up and down. And so I spoke with a counselor prior to my cancer diagnosis, but I asked to be as part of the psychosocial program because it was more cancer related. And my counselor said, I don't know enough about the cancer, so I would refer you there. So I've been doing both.
Okay.
And I think it's great.
Mhm.
So don't do it alone, don't go it alone. It's been wonderful. And yeah, that's something that's really helped me a lot. That's right. Yeah.
Thank you. Scott or Wendy?
I just reiterate what Kathleen says. Yeah, don't let that, if you have those feelings of emotional distress, don't let them take over your life. Don't let the stigma of seeing a professional stop you. You need to do it. And take care, the most important thing is to take care of yourself.
Well, it's such a roller coaster. Get back to that again. So I guess go by how you feel. I mean, you're going to feel like not being around people. And I guess, send out the message that you do want to have contact with people. So when you are feeling like you can be around people, whether that's to talk about the diagnosis or just to socialize, just to be with people who you can laugh with, that is very important.
Yeah, so not to do it alone, I guess, eh? Okay, well, thank you very much. Oh, there's a question.
Yeah, I do have a question.
Go ahead.
Have you found, certain, I have found, so I'm wondering if you have found that a lot of people, they really don't want to talk about it?
I think that's partly true. The oncologist I see, she said to me, some people want to talk about it all, others don't want to do anything, like it really varies. But like Wendy mentioned, don't let the stigma, of getting help mean that you're weak or whatever. Like you have cancer, right? You need help, it's overwhelming, right? Every day I wake up and it's like, okay, am I overwhelmed? What do I need to do? Like every day, right? So it's okay to get help. I don't know if that helps.
I don't have a problem with getting help. I think the thing I find most difficult is that most people, like my children, don't want to talk about it. It's like, oh, you're strong, you'll be here, it's gone.
Yeah, that's a tough one, right? I think many people have had that experience where some people you were expecting maybe to be able to talk to are not there. I always say you're the driver of the car, so if possible to be explicit about, okay, I want to talk about this, or no, today I don't really want to talk, I just want to socialize, I just want to have a laugh. I find that a lot of people are not sure how to support you. They're afraid, well, if I ask, that's going to be bad. If I don't ask, that's going to be rude. So they're kind of looking at you and be like, well, what is it that you need? And just be upfront and say, yeah, today I don't want to talk about cancer. Or today, you know what, I really do need to talk about what I'm going through.
Okay, so comment to add to that. I think it's important as someone who has an illness that it is okay and important for you guys to be able to talk about it and to normalize it. And, I use this line a lot, but having a conversation about what it is in that moment isn't going to change the course, but it's going to ease some of your anxiety or your distress that's building up about things that you want to be able to talk about. And so I use that line a lot. Us talking about this isn't going to change my hope. If anything, it might increase my hope. It changes your perspective and it might change theirs, right? We need to normalize this. And so if you guys are able to talk about it, it's amazing.
Well, I can talk about it.
But encouraging everyone else to do it if they,
I can
we
talk about
should
it
be.
better with my grandkids than my own kids. But yes, I will push. Thank you.
Yeah, I can see it with families, the switching of roles, because, being a son myself, I see myself, taking on more of a parental role with my parents. And I think, especially if it happens to someone very young, and like if they have teenage kids or young adult kids, they want them to, they don't want to burden them with it, or they're just not for whatever reasons, there's a difficulty there in talking about it.
All right, well, thank you very much, and thanks for all of this. Thanks, you guys, for doing this.
Thank you to our patient panel. I know how hard it can be to come up and speak, but I hope you found it rewarding, and I know that everybody could relate to the things that you were saying. So thank you again. So, just to tie things up, thank you everybody for attending. Thank you to all of our volunteers and our speakers and our participants. And please have a look on our website for all the activities that are coming up in November for Lung Cancer Awareness Month. We've got lots and lots of great events planned. Thank you again.